You can't imagine.
So we are live now.
All the time. Anytime.
Good afternoon, everyone.
Yeah.
Ines Hernando, and I will be moderating this webinar today. I'm Eurordis year-end healthcare director. And today we have with us three speakers. So we have Michel Battier, who's the Eurogen year-end project coordinator. Dr. Nazide Manger, who's, I believe that is the way you pronounce your surname.
It's very good at that. So it is Nashide, but you could say.
Okay, Nashide.
Nashid.
She's a urology surgeon and she works at Sheffield Teaching Hospital. That's a member of Eurogen ERN. And they will be explaining us how they're using the CPMS in Eurogen and showing us, explaining and sharing with us a little bit the uptake of the tool across the different ERNs and how many panels they have opened and how is this working for them. And then we will have a question and answer slot, 15 minutes. And after that, we will have Petra Wilson explaining the CPMS informed consent form. So Petra is the managing director at Health Connect Partners and senior advisor at FTI Consulting. But most importantly, she's the brain behind the informed consent form. So she was part of the team that developed that consent form. So, and after that, you'll have also an opportunity to ask your questions for 10 minutes. Right now, you're all muted. I will unmute you when we start with the questions and answers. I would ask all the participants, I see that we have 24 participants right now. I will ask all of you to do the questions and answers to the, so if you see the menu on your screens, there's the Q&A icon. So if you can use that to make your questions, I will really appreciate it rather than the chat box because it's easier for us to track them. So that will be very much appreciated. So yeah, over to Nazide and Nashide and Michel, please go ahead.
Thank you. So hi, I'm Nashid. I'm a urologist, as Ines said. I've finished my core training, but I'm still continuing to my subspecialty training here in Sheffield with Prof. Chappell. And in the last 4 or 5 years, I'm also doing my PhD studies, which I'm hopefully finishing this year. And in the last year, one of my duties have been to help Chris Chappell with this CPMS. And obviously, it's a very good training environment for me as well. So I happen to know it, know how to use it, being younger maybe. But anyways, I'm very happy today that we are discussing this with all the patient representatives, because I think it's important that they know what we are doing so that they can get actively involved and then the system runs better. Now, I am sharing my screen. So I will start and then Michel will continue. Yeah, I think, yes. I think my screen is now available for everyone to view.
Yep.
So yes, so this is the outline of my presentation. I will first tell you how I see CPMS, then how I use it to discuss some rare and complex urogenital diseases, because I'm involved in Eurogen. And I will try to give you some examples, 3 examples from the panel discussions we had. And then I will finish by some feature, what we could be doing in the future with the CPMS. So CPMS is a secure web-based system. This is like a virtual room where experts from different disciplines can come together and discuss some patients or cases. So they exchange experience and expertise. And obviously it is essential that this environment, because there's patient information, it's essential that it's secure. And I think CPMS provides us with that environment. And from a trainee's perspective, this is an excellent environment to get trained on certain aspects of these rare and complex diseases, because you would meet all the experts there. And also this has a great potential to be a big data set, a health data that could then be used in epidemiologic studies, any research. So I think it's really exciting. From the patient's perspective, obviously this is designed to improve the quality of care and increase access to experts on rare conditions. Now, I will quickly switch to how I use it. The first thing you need to do to use the CPMS is to register yourself. There are 4 steps, and you go to the website, create an account first. This is like creating an email account, but then you go back again and request access. Then the ERN coordinator approves it or rejects it. And then if you are granted access, then you can log into CPMS. While you are logging in, I will show later on, you have a 2-factor authentication system that makes things a bit more safer. I think this is something you would maybe use when you're logging into your online account. So this is something similar to that. Now, when I log into CPMS, I would have several roles for a healthcare professional. So the simplest one, the most basic one, is the point of care physician. So this is your doctor who is treating you at your local hospital that may or may not be an ERN member. So if it is not an ERN member, then you are still the treating physician. You consent the patient for CPMS and fill the consultation form. But after that, if you are not an ERN member, then the ERN coordinator directs the discussion to a panel lead, and then the panel lead continues. So this is to ensure that you receive an expert care, so to say. And so we have point of care physician. If your point of care physician is in an ERN affiliated center, is a part of the ERNs, then he can be the panel lead, or may not be. That's on ERN coordinator's discretion. But panel leads have a bit more of control on the system. For example, a panel lead could invite members to the panel or ask ERN coordinators' assistants to invite guest members or members from other ERNs. Now, ERN coordinator is on top of all these people. He is kind of responsible for all the actions in the ERN. He can be the point of care physician, the panel lead, and he can invite experts from other ERNs. The ERN coordinator also can forward the panel to another ERN if he thinks it is not relevant to a particular ERN. Also, their ERN coordinator will have access to all performance evaluation data and who is doing what. So these are the main roles that you would see in the CPMS. And I wanted to make a flow chart, like how a virtual patient's journey on CPMS is. So what happens is you see your healthcare provider, your doctor at your local, wherever you are treated, and then you need to give consent to be involved in the CPMS. After you give your consent to your point of care physician, then the information is uploaded onto the CPMS. And then the ERN coordinator either assigns a panel lead to lead the discussion, or if he finds it not relevant to this ERN but another ERN, then he could refer you to another ERN. But if you are staying in the ERN, there's a panel lead that is assigned by the ERN coordinator, and the panel lead sets up an expert panel. At this point, he can invite members or experts from inside or outside of ERNs. But the panel lead sets up the panel, and then the panel members can review the patient information, and then they request additional data, or they can give your comments, and then it comes to a point where you complete the data, complete the assessment, and at the end of the assessment you would sign off, prepare an outcome report, and then close the panel. So this is a normal flow of events in the CPMS. Now I will demonstrate how I do it. I have done pre-recorded videos. This is the first page you would see after you log into CPMS as a health professional. And the main thing happens here. I want to show you the secure login system. So there's an excellent video here. This is something they added later on, and I think this is very useful. This is telling anyone at any level of IT how to log into CPMS step by step, and it is 8-10 minutes video, and it's really good. And for example, if you are working somewhere in Romania, Lithuania, you could be not the Y generation or a bit maybe older as a doctor, but I think it's for all levels. So this video is really good. Then you follow this, you log in yourself and I request access. And then if you are granted access, you come back to this page, and then you enter your email address, password, and you choose a second verification method. Now we use this mobile phone, so we receive a text message to our mobile phones that is registered with the system. So I would enter my phone number, and then I would receive a code. Then I'm logged into CPMS. Now there's other ways of verification as well. So there's an app that you could download, and you could generate a code with the app. Or if you do not have internet access at any point, for example, sometimes in theaters we don't have it because it's blocked, you could use other means of verification. There is also this token system, but I think that's for European Commission people, so I've never used that one, but it's good to have them. Now, after you log into CPMS, this is what you see. I use 3 tabs, basically. The center tab here, that is where all the information in Sheffield is located. And we have ERN tab. This is where we are connected to all other ERN centers within our ERN. And we have these training videos. Now they have put several training videos. Most of them are really, really nice, very useful. Some of them are a bit too long. I find them a bit too long, which is good for if you want more detail. But you know, it's sometimes maybe you prefer like small 3-5 minutes, easy, quick videos. But I think they're going to update them, but most of them are really, really useful. So now I will start. I did this pre-recorded thing. This is how I use the center tab. The center tab is anything in Sheffield in my own hospital. And then how I do it is I click on the center. The main thing I use, you can see, is Sheffield. And this is how I start enrolling a patient. The system assigns an ID. This is automatic. And then all authorized users from the same center can see the information. Now this is the data enrolled, and then now we have here, this is really good, because previously we had just consent, yes, no, date of consent. Now they made it more specific. So I need to write, did the patient consent for care? Yes, what is the date? Did the patient consent for registries? Yes, no, and the date. So if it is asked like more specifically, I think it's now better. So we approve, so we write here if the patient gave consent or not. And then if I go on to say enroll, it gives me a warning saying like, are you approved by the ERN coordinator? Do you accept all responsibilities? Then you click yes and then go. And you also would find there the consent forms in every language. This is the English language one, and I think this will be covered later on. But this is consent for care, for registries, and to be contacted for research. So you could find the latest version of all consent forms in this enrollment page. Then I have patient list and panels, but I can't go to patient list. So I move on to, so after I enroll a patient, I go on to create a panel. This is where I first write a consultation form involving all patient information. And this is where I start de-identifying patient's identity. So I give a nickname, and then you could write all the patient information first. Why are we requesting the consultation? What's the reason? Where do I work? What do I do? Who is the panel lead? So these are all patient information. Then you go on to describe in a very, very detailed way everything about the patient's condition. What is good and what I like about this is all these tabs contain a lot of details, but they are not all of them are absolutely necessary for you to proceed. So you can have the option to enter as much detail as you can, and you are encouraged, but you also can omit, for example, a pedigree, like a family tree, because we don't use it, so you don't have to do it, but it's there as an option. So you can write everything either as an attachment, or you can type here the text, the complaint, the symptoms, laboratory findings, exam findings, imaging findings. So it reminds you, and it is, I think, really good. It's working well. Then what else do you have? Yeah, you have laboratory findings here. You can choose from default formats, but you can also type it. But I generally type it because our system is not yet integrated. Then your rare disease diagnosis, comorbidities, any genetic, any family history. This is the pedigree you can use if you want to. All other health behaviors. So you have everything here, basically. And then if there's any allergies, any medications. Now, what is really good comes next. There's a section where we could actually upload any patient video, any examination findings, any findings in the operating theater. And also we could upload any MRI, CT, any radiologic investigations. And later on, we will see how good this medical documents tab is working, because then you could play with it. So you upload and everybody can see it. Then, so after I set up the consultation form, I go on to my ERN tab, and I go to panels in this section. Like most of the action is here, and as you can see, all patients are de-identified here. You have panel numbers and the dates. Now in this panels tab, I can see all the panels in my own ERN. And some of them, for example, for this one, I don't have access. So I can only see the ones that I'm invited to review. And you see nicknames, date, panel lead. Now I want to show you one of the panels we did. This was one of the first, so this was the first or second. So this is how a panel looks like in the CPMS. You see our center is Sheffield Teaching Hospitals. The panel lead is Chris Chappell. You could see the panel members here. As you can see, we have a pediatric urologist, a urologist, a nurse specialist, a urogynecologist. So we have a variety of expert opinions there. Then I have my patient's nickname and why I asked for this panel consultation. And this is a detailed history. You could write as much as you want, but we try to make it clear to everyone. Then this is the medical documents bit. Now, for this particular case, it was really important that all panel members would review the MRIs because this patient has a cyst very close to her water pipe, the urethra. And then we could manage to de-identify all the radiologic images and then upload them onto the CPMS. So as you see, there is no patient information anywhere. And then the quality of images, you will see a bit more. Now they look even better because I recorded this. The quality is a bit poorer, but so here's the MRI. You will see the cyst soon. So I can go through all the slices as if I would do in my own hospital. So this is the bladder. So we have the cyst somewhere here. And then I could play with the image, I could play with the contrast, I could make it bigger, smaller, and then I could move it. Now I will go to my area of interest. So this is my cyst here, for example. I can do measurements with this one. So if I want to know how big a cyst it is, you could measure angles, and this is really, really good and very useful. So this CPMS allows access to this really good quality medical imaging together with all the history and everything. And then we have this timeline on the right-hand side. This is where all the panel members can communicate. They could ask something. Some professors are very good at writing all their comments. This is what we want. This is what I wonder. So there's a way for you to communicate in a written language. But we could also set up virtual meetings like video conference systems. Now, another feature of this ERN tab is, I think, yes, now we have my meetings section. This is also nice. This is where, so we had all the written information that all the panel members could review. And we could also arrange meetings like we meet here. We could do video conferencing. And we did them in the past. And as you can see, we would see here the participants. And you could also record all these video meetings that you had. Now this is really good because you could establish a very good communication with other experts. And I wish I could show you one of the nicer ones, but I couldn't record it somehow due to IT reasons. But I have recorded one trial meeting that we had with our German colleagues here. And you could see me, but on the other side, we could have other colleagues in Germany, and we did this trial meeting to see if everything was working or not, and we could manage to record this. But you could have in this meeting 4 or 5 members, and it is, I think very good quality communication. You understand each other very clearly. You see each other. It's like the best of what you can do, I think, in a virtual environment. And you can also record them, and that is good because then they are documented as well. Now, this is something you could see in every panel page. This is showing the workflow, so where you are. So you first start with opening the panel, then you select the panel and data assessment stage, outcome, sign off. And this is what you want to see ideally: sign off, panel closed, and job done. So now I want to give you an example of a nice panel we did. This was a patient from Lithuania, and the referring physician was a very young, really highly motivated young lady, I think. And so she uploaded the information onto CPMS. This was a patient with interstitial cystitis. And here also the Center Vilnius panel lead. We have our panel members. We have 2 colleagues from Germany and the referring physician. And this is again an ERN member, but they didn't know they were ERN members until. But anyway, so this is the panel we discussed. So a very detailed description of the problem. So she's typing all this information basically onto the CPMS, and all the laboratory findings, all the imaging findings. We had here a feeding cystometry, a bladder diary. And then I scroll down, cystoscopy findings, what they did, what they had found, all the medications, everything. Very good. Then I come to that later. This is the outcome report we produced later. So at the end of the meeting, I think we were able to, because this didn't require any surgical intervention, like maybe other cases would, but this was a really useful clinical advice, I think, and that really helped at that point for the management of patient where so in Lithuania again, so she didn't have to travel. And I think we have given a useful advice. That was the feedback we received. And at the end of each panel, so when you complete the job, you produce an outcome report. And then this could be shared with the patient. This is what we discussed. This is what what our opinion and recommendation is. And then, yeah. So this is an outcome report. And I think patients have right to access this. And then we finish it, sign off, close the panel. So this was a really good and positive case, I think. And I think everybody was happy with what we had done. This is another example. Let me see. So yes, this was a case of endometriosis. This was really complex. This patient had undergone several operations, and we were discussing a few more maybe. And as you see, we then involved a urogynecologist and a clinical nurse specialist in gynecology. And we have urologists from Germany, Belgium. And this is the description of the problem. I scroll down. So some laboratory tests. Sometimes, now because this was a bit complicated and long, there was not room for, so there's a limit, I think, word limit. Then you needed to do a separate file to describe the problem. And then what had been done, when it was done, what were the results. Then you have a lot of tests also. So you would imagine, so you could have like every 6 months, maybe you have follow-up scintigraphies, maybe tomographies, maybe MRIs. So we wanted to put everything here. But obviously, because this documentation here, now this is very useful, obviously, we downloaded everything, but because it's not integrated to the hospital system in our case, I had to select the most important images. Obviously, you could come back if the panel members ask, like, I want to see this image at this time point, you could edit as well. But yeah, because the system is not integrated, you pick up the most important ones and then upload it here. And as you can see again, I have scintigraphies here, MRI images, tomographies. You can see each slide, all are de-identified. And I think anyone who could view these can make an informed decision. And you see the quality of images are really, really good. And then you can scroll down, change your contrast, measure to whatever you want to do. Now I close this one.
Nashida, you have 10 minutes now. Do you want Michelle to take over, or do you want to continue?
Yes, I will continue very quickly and finish.
Okay.
So this is the outcome report we produced. Another example we had, now this is something maybe we need to improve a bit more in the future, because we also had a case that we were asked to review from, I think this was Romania. So the treating physician was really wanting to ask expert opinion for another case of interstitial cystitis. And we sent all the information, this is how you log in, And then somewhere we exchanged several emails. So she was also motivated, but somehow she got lost on that track, so she couldn't log into CPMS and then upload the patient information. And so this is a case where it didn't really work, but this was a physician who was not in an ERN member center. So I think we may need a bit more improvement on that side. So the problems could be because that person has to enter the patient information in English. Maybe that may have been perceived as a barrier, I don't know. Or maybe she may have found it maybe a bit more technically complex to manage this IT stuff. But as I showed, it's quite straightforward to log in. But we didn't get feedback, so we don't know. Or maybe she may have very time constraints. So yeah, so this was another case. So conclusion. CPMS, I think, is a very good platform that you could effectively use to discuss some rare and complex cases. You can establish a very effective communication across borders in with experts from different countries, and you have access to patient history laboratory tests, images. You can upload physical information, findings. If you want, you could add videos, images, everything. And also I find it, from my point of view, that's a very good environment for training, and also a very good environment to as a research database, because you have potentially you have access to a very wide health data set. What could improve? Now I was thinking, and I was while preparing this, what we didn't do, maybe, I mean, we always receive feedback at any time, but I think we didn't specifically ask for the patients that we completed the panels. So we produced outcome reports and shared it with the patients, but we didn't really specifically ask for feedback. Maybe that could, I mean, they said, they expressed their happiness to us, but you know, you maybe formally asking and recording them, keeping a report would help, and that could be something we could discuss. And also we could ask feedback to physicians as to how their experience in the CPMS was. And also, Yeah, I think it's working up to now. A bit better with ERN member hospitals, because you could imagine there are academic centers, there are young people who are willing to be involved because it's good training. So in ERN member centers, I think we can say that it's running really effectively, but maybe more improvements could be done in maybe non-ERN member centers. And also we are at a process of setting up registries and databases, and we are also preparing some webinars that could first involve some training videos for some surgeries that we performed. And now I've finished, I think. Now I will hand over to Michelle.
Thank you, Nazid. Hello, I'm Michelle Batty. I'm the Centre Manager for Eurogen. So I'm basically like a little bit of glue in the middle of all our 29 healthcare providers, which are based in 11 member states. I wanted to try and give you a little bit of context. So in our European reference network, a number of them have taken lead responsibility for certain areas that are important across all the ERNs. And Prof. Chris Chappell agreed to take on the lead role for the system that is going to be set up to monitor and assess all of the ERNs. So there are 7 working groups working at European level, one on monitoring, one on research, one on knowledge generation, etc. And different coordinators lead different working groups. So Eurogen lead the monitoring and assessment one. And there are 3 main dimensions of this, really. At the moment, we're just at the very beginning of this work, and it's got to be step by step. So what we've been working on now is to agree a set of common indicators. So those are indicators that can be used by all of the ERNs. So they could, and some of those indicators look at capturing the information coming out of CPMS. There's also the periodic self-assessment of the ERNs and their healthcare providers. It's also important to know the number of patients that are being treated by the healthcare providers within each European reference network. That gives us an overview of all the patients, whereas an ERN patient would just be those patients that agree to share their data in CPMS and then receive an outcome report after a panel discussion. And a third level is going to be the periodic assessment and validation of the expertise of the healthcare providers within the reference networks. And the Commission and the Board of Member States for ERNs, which is the group that oversees the governance and checks how the reference networks are working, which is made up of representatives from member states, so they're national level representatives. So there should be some role in the future for member states at national level to be checking the expertise of their ERN healthcare providers, because they will need to maintain those levels of expertise, maintain those levels of resources, and maintain that capability to have a very wide MDT capacity, multidisciplinary teams looking at cases. So the continuous monitoring of the ERNs, well, basically we started in 2017, and the ERNs will be evaluated by the Board of Member States every 5 years. So what we've just agreed is a set of 18 performance indicators which will monitor all the ERNs. So that's a common set of indicators. That will include some of the data from CPMS around clinical activity, and also other networking activities like dissemination of the ERN message at congresses, conferences. And as Nazid's really helpfully touched on, this knowledge generation is very important, because what we're seeing through use of CPMS is that expertise going from some of Europe, and indeed some of them are world specialists in their particular area. And it's very helpful for younger, perhaps less experienced healthcare professionals to listen to those experts in the panel. And also, as Naseed mentioned, stimulating research activities. These are networked together some of the best healthcare providers and best professionals in Europe, so they can really collaborate around clinical trials, that kind of thing. Step 2 of the monitoring process will be, it's more difficult to do, but it's going to be each individual European reference network will be looking at defining some specific outcome indicators based on disease or thematic area. So in our case, if we've got the rare urogenital cancers, we'll be looking at survival rates, we might be looking at organ preservation rates, things like that. Or for another one of our work streams that deals with the functional urological conditions, we'd be looking at things like measuring incontinence and quality of life, things that are much more important to the patients. So once we've defined with our clinicians these outcome indicators, then we would normally send them to our EPAGs, to our patient representatives, ask them to review the indicators to make sure that they agree with what the clinicians agree with, because sometimes expectations are different. So it's important to bring both of those groups together and talk about what matters most. And I mentioned that there's periodic self-assessment and reporting of the ERN so that we know how many patients we're treating over time. Now, this is something called the CPMS status report. This is a monthly report which is system generated. It comes automatically from CPMS. And it gives a lot of very useful information. So if you look at number of users registered, you can see that a total of 943 people clinicians have managed to register with CPMS using the training videos, etc. And you can see how many have logged on at monthly. Number of panels, those, as Naseed explained, those are the healthcare professionals, the experts who are participating in the multidisciplinary live meeting, reviewing the medical information of the patients and giving their expert advice. And I'm always really pleased. If you look at number of panels, you can see that Eurogen is just about in the lead by a very small margin. So actually we're the reference network with the most active use of CPMS, which is really nice. The European Collaborative Platform, this is basically another IT tool that the Commission has given all the reference networks, and this is really an information sharing. This is where we can share all our documents. We have a library, we have a calendar for events, and the interesting thing about this is that our patient organisations via our EPAGs can access, we give them access so that they can look at all the documents that are about the reference network on the European Collaborative Platform. This is some of the key performance indicators which are already included in CPMS. So the coordinator, Professor Chris Chappell in our case, can access this data. So you can see the number of panels open, the number of panels closed. You can have a look at who's the most active user, which is always quite nice. So you can send them a little email and say who's the most active. But of course, I mean, I should say we're very much beginning with this. We've had the system since November last year, and it really is, we've been taking a step-by-step approach. It's very much about making sure that people are comfortable with the system, supporting them to watch, making sure they watch the training videos, and really going step by step as you become more familiar with it.
Michelle, do you have many more slides?
No, I'm going quite fast.
Okay, thanks.
Yeah, so that lists the panel leads, I think. Yeah. And I mentioned our indicators. So these were some of the indicators that our working group has been looking at. And there you can see we've got the number of patients entered into CPMS, total volume, number of patients who've had a panel review. We dropped the emergency one because that actually wasn't relevant to all ERNs. Some ERNs, like the paediatric cancer one, will be having to deal with some of these cases more quickly, so would we, but it's not relevant to all ERNs. So on the one hand, we've just identified a set of common indicators that are relevant to all the ERNs. And then phase 2 for 2019 will be indicators specific to each ERN based on the disease areas. I think we can skip that one because I've actually mentioned that. Yeah, so I won't take up any more time because I think we've tried to give you a brief overview of how we're using CPMS. And I think what we can say is it's working really well so far. And I think it's really important for us to have a chance to listen to some of the views of patients and hear what they think about how we're using their data, and any feedback is welcome. So I'll hand over to you now, and then we're very happy to answer questions.
Thanks. Thank you very much, both Michelle and Naside. So I have a couple of questions here from Elena Moya, and also Paula Morandi was asking a question at the beginning, so she raised her hand. So I'm going to unmute Paula so that she can ask her question to you. So you're in, Paula, you can now talk, I think.
Hi, can you hear me?
Yeah, we can hear you now.
Oh, thank you. Yes, I was wondering if I'm talking about the data protection and how this goes along with the I suppose national privacy laws. Does that create a problem having different privacy laws from one country to the other in the EU?
Paula, maybe we can come to this question after the presentation by Petra, because that is more of a legal aspect that Petra will cover. But
okay,
she'll explain that we have this. Well, she'll explain everything about the nice regulation that we have now.
Thank you. Okay, thank you.
Yeah. So let me just. You can see Elena's questions, so she has typed them there. Can you see them, Naside and?
Yes.
Or I will unmute Elena anyway, because then she can also, I'll unmute her because I think it's nice. Elena.
Hello.
Hello.
I typed 3 questions. The first one is, I know, for example, in Spain, they have already electronic patient history. In Germany, we don't so far. Some places they have it, but others are still not that far. So not at a place, not at a server. So is it already possible to upload this kind of imaging or whatever, if it's already in Spain, to this platform? Or do you have to do it all manually? So it's enough that you say, we need this patient and the whole patient history is going to be uploaded, or do you have to do it step by step?
Well, I'll just make some comments. Actually, what CPMS has the capacity to do, the developers have told us, is it can interface with electronic patient health records. And of course, the difficulty is as many different hospitals in different countries use different systems. So the European Commission is currently piloting this now with 4 hospitals across Europe, but it can't happen automatically. You need a very intensive period of working with the IT team based in the hospital. So it's quite difficult to persuade the hospital to invest the time and resources in this. However, out of the 4 hospitals, 2 of them are in Eurogen. One is Hamburg in Germany. So they've been using their electronic patient health record for many years now, 8 years. So they're piloting it there, and they're also piloting it in Radboud University Medical Hospital, which is also in our reference network. And in fact, they've got 14 ERNs running out of their hospital. So you can understand why they want to invest some time and resources into the interface, because then there wouldn't be any need for the manual inputting in data. I don't know if Nazid wants to comment there. Or...
Yeah, practically, I mean, I need to enter everything right. and then the images, I wish they were connected, but I also understand the hospitals won't easily let all because I think if once they are connected, which patient, you need to select which patients consented, like, I don't know. So at the moment, what happens in Sheffield is you do everything manually. But I also know a friend in Brussels who can very easily automatically upload. So it depends. But I think we could assume that at the moment everybody is doing it. Not everybody, most people are doing it manually. But the idea is that all the data in all Europe, all the health data is connected and accumulated in one single database. So that is the idea, and it would make my
it's your dream, let's say.
Yes.
Yeah. I could imagine. So it's possible. It's possible, but it might be like that in all centers in 20 or 30 years.
Exactly.
But I must also say the positive side is I review everything. So
yes.
if I type it, all unnecessary things are deleted.
It's also
whereas if you put everything there, then people will get like, a bit of editing. Editing and making it, well, this is the positive side if you want to say.
Yes, as a review. So the second question was, we were talking about language barriers. There are already translator tools like the one in Rare Connect, which translates everything. Also the comments in the groups you choose. And so I just wrote Facebook and Instagram, but afterwards I thought about Rare Connect, which is from Eurordis. So they are translating already automatically. So it won't be possible to implement such a translator tool, because I think many doctors won't participate because of language in many countries.
Yeah, I think what is important for me, the concern is for ERN member centers. I think I could imagine there would always be, and we have seen very young people, very motivated, fluent in English, no problem. But I think my real concern would be if there is someone who is not very comfortable with this language, IT skills, and who can't refer a patient although he wants to. So I think that's the problem. And how we could solve, I don't know a measure to solve it at the moment that's in place and that's working, but this can really be an option and we could implement it somehow. But I think we need a bit more of awareness because this is really rare. Even the ERN centers, we could just manage to get everyone into the system, get it using. But yeah, I mean, what could we do? But we need to do something for.
That's a big, translation is a big problem.
Yeah, I think more about the Eastern countries and.
Yeah. So for your question. Sorry, Elena, because I have a couple of other questions. So yeah go ahead and ask the one. Yeah.
Michelle said at the end that the outcome indicators it was point to, are they center specific, rare disease specific, or ERN specific, or is a mix? So in your center, you are involved in different ERNs. So are you going to have different outcome indicators?
No, in my, so some hospitals, some particular healthcare providers could be involved in several ERNs. I'm only involved in Eurogen, but okay. Eurogen is leading for all of the 24 reference networks, a working group on setting up a system to monitor and evaluate the ERNs.
Mm. Okay.
So we have a lead function around the monitoring and assessment process.
Ines, I think there is there are written questions.
Yeah, There is another one, just very quickly, because there's Julia also asking through the chat. So let me go very quickly back to the chat.
So she's saying, is the CPMS able to use any for doctors, hospitals, or can be used from patients also? No, it's for only healthcare professionals use. I think it's.
And I think perhaps Petra will correct me later on. I think that's related to the data protection regulation and the intensity of it. Basically, no one can have access to the CPMS system unless you have absolutely essential reason to access the system and look at the data. The more people that can access a system, I think the more you could have potential breaches. So the information is restricted to a need-to-know basis.
There is another question on the liability if something goes wrong, but I think that Petra can cover that because again, it's a legal matter, so we can have her covering that. So we're on time. I'm so happy. Just very quickly also on what...
There's another question. Did we overlook this?
Yeah, I think that it was Elena's questions and then we answered them.
From Julia, I think. How can we help patients without using this system?
So she's wondering, that's a rhetorical question.
I think that's a good question because we were in that position. So what happens is we normally receive an email generally or a notification saying, I have a patient, can I discuss it onto the CPMS with experts, blah, blah. And then if they can't make it to the CPMS somehow, and I think we did manage one case over phone, but obviously I don't think that is ideal for patients because it's better if it is formal, if the advice is there and everything is documented. But yeah, how can we help patients without use of this system?
Or a similar one. I'm trying to unmute you, Julia, just in case you want to.
Well, I think what used to happen in the past is clinicians would exchange, hopefully not patient identifiable information, but over email. And in the new framework of the GDPR, that's, it's absolutely not secure and it should not be happening.
And I can't think of a physician commenting on, well, clearly not for a specific patient, because you can't if you don't have all the information. You could discuss how would you manage something like in a general sense, but I don't, there shouldn't be any advice on a particular patient unless, so this CPMS allows it, that is fine because you are liable, everybody, you see all the information, but still.
So Julia cannot talk because there's something something with her mic is not working, but thanks for addressing that question. And on the question that Elena was asking about interoperability, I can just say that there is some very structured information that will be easily kind of integrated, and that will be more, quickly with with the images. That's very standardized and it's straightforward, and it will happen quickly, I think, not with the unstructured data. And there's lots of, and you've seen it, there's lots of unstructured data in those reports. So it will take time, and it's true that what we are seeing here is, and allow me to say this, but it's like we're again reproducing another baby patient report, electronic patient report or patient record in the CPMS. That will be there. The one that you have in the hospital will also be there. So we're just creating another database there. But anyway.
No, there's another useful comment there.
Yeah.
Russell.
Thank you.
So he's saying.
Russell, what is he saying?
Outside the system. So healthcare providers outside the system will have to input via an ERN member. I think that's a very good suggestion. So, for example, if you are in Romania, you are not in an ERN member, but can you find someone, maybe an ERN member close to, a bit. So if you find an ERN member, that solves the problem. And if this is a rare and complex case anyhow, why not refer it to somewhere, at least, I mean, I think that's a good point.
At national.
Okay.
Well, in fact, that is actually what's supposed to be happening. We're expecting the Board of Member States for ERNs to appoint affiliated partners. So those will be healthcare providers in member states where there is no full ERN member. So that will address the geographical gaps of where there aren't any members of a particular reference network. So we hope over time those affiliated partners would be making the referrals into the ERN system, but a referral should only be going into the ERN system if it can't be adequately solved and addressed at national level.
But still there is a way for any non-ERN member physicians, for any physicians to ask access to CPMS. So it's not ruled out. You don't have to, you can skip the ERNs. So you are free to skip any ERN and I will go myself. Yeah, you can say it as a physician. But I think this is really good way. It is first asking any ERN member, national level, and then.
But that's where we need the help of the Board of Member States. We need national governments to appoint these affiliated partners. And we're hoping that will happen in 2019, but the deadline for when they're going to appoint them keeps slipping. But once they're appointed, we expect to see an increase in referrals.
Yeah, me too. Let's see. Thanks for that, both of you. Really, really appreciate it. There's just a very small, last question by Beverly here. How to find when an ERN CPMS goes live? So all of them are live since what was it? November
2017. CPMS went
so
live.
they're all live, meaning that they are all up and running. They all have the system.
Yes, I think.
Yes, you go ahead. No, you
well, you can see from the graph I showed you with the most active users of CPMS, some are much more active than others. Some are only just getting going. And from what I can gather at the meeting of the ERN coordinators, the biggest barrier to some reference networks saying they don't want to use CPMS yet is data protection at local level. Some hospitals are reporting back that their data protection supervisor or whoever it might be at hospital level won't let them use CPMS.
Okay, so now over to Petra to cover this issues on data protection and see. Thanks for that. So Petra, how do you share your screen? Here. Yeah. Okay. This one. Oh no. That's one. Yeah.
Shall I mute myself?
Yes, I think so.
So hello everybody, my name is Petra Wilson. I was part of the team that wrote the original, or the consent form that's still being used. I'm going to give you a short presentation on what the background is, so what the GDPR says about this kind of data sharing, and then run through the form. You saw a brief glimpse of it earlier on. But I do want to leave some time for questions, and notably there was a question earlier on about liability for both the care and for any data protection issues, so I'll come back to that afterwards. So let me, yes, okay, it's coming up now. So I'm diving right into the principles of the GDPR because we don't have time here to go through all the stories of the GDPR. Can you hear me better now? No? Yes.
Okay. Technology. I'm supposed to be the person who can do this stuff. Okay, now maybe you can hear me better? Yes, good. Okay, so the GDPR very quick point, it's a regulation. A regulation means it applies in all member states almost as it is written. It's not that's different from a directive. A directive is just a guideline for how a member state is to adopt national law. However, there are some variations allowed, and those are particularly around the issues of research. Now, there was a comment made just now, I think, Michelle, you made it, that some people are still uncomfortable about the data sharing, and they say that their national law doesn't allow it. That's something that we could contest, but on the other hand, we don't want to be confrontational. There is, to my knowledge, no national law that does not allow for the use of the CPMS for care services. There may be some pushback about using the data for later research, because research is a matter of national competence. But let's go back to what the GDPR says. The key articles that you need to be aware of are 5 and 6, which set the core principles of how and when data may be used. And first you have the 6 core principles of how you must treat data. And the key things to note here are the 3rd bullet point, data minimization. You have adequate, relevant, but only limited to what is needed. Now, we do need to be careful that sometimes you may get very wide information in a medical record that arguably is not necessary. This is particularly difficult when you have issues of family history. And this is particularly relevant because you will get consent from the patient, and that does not mean that you get consent to sharing information about the patient's family. But as we all know, family history is important. So there are some issues to be careful about there. You also have a duty to make sure that the information is accurate and, where necessary, kept up to date. That means that if there is something new in a record that you need to share, you actually have a duty to do that. And then there are the duties around storage limitation. You keep it only for as long as necessary, and you keep it with integrity and confidentiality. Now, how long you keep medical data is usually set in national law. Almost certainly you keep it for the lifetime of a patient. In some national laws, as soon as a patient has died, their record is no longer a medical record, is no longer a confidential record. This is because rules around data protection accrue to a natural person, and once somebody is dead, they are no longer a natural person. Therefore, in some countries, there's no data protection issues at all around the records of a deceased person. However, because I've already said the records of one person also say things about other people in their family, many countries have a special protection which sits outside GDPR but is very similar to GDPR, which may protect a record for 20 or 30 years. So that's one thing to be aware of in terms of national variation. Alongside these 6 core principles, we then come to the, again, 6 rules according to which you can share data. Now, all the presentation we've had so far is very much about the consent of the data subject, the patient in this case, to sharing their data. And this is something that the Commission were very keen to use in the ERN system because they wanted to promote positive attitude about it. But what's really important here is that it isn't actually the only reason. And if, for example, it was in the vital interests of a patient to set up a panel and discuss their case, and that patient was for one reason or another not able to consent, you might have a mental health patient who doesn't have the mental capacity to consent. You might have a patient who is very ill, who doesn't have the mental or physiological capacity to consent. And you might have a difficult case of a pediatric situation where, for matters of child protection, you actually don't want to seek the consent of the parents, and you're going to go ahead in the vital interests of the child. So it's important to note that while consent is the best way to go, it's ethically the right thing to do, it actually isn't the only basis on which you can share medical information. I'm not going through the others in detail on the interest of time. The other thing to bear in mind is that we actually need to step back and remember that the GDPR, on the face of it, in Article 9, says that sharing data related to somebody's political life, health, or sex life is not allowed. And then it goes on to say, but there are exceptions to this, and this is again where the consent comes in. If somebody consents, you can share the data, or, and here again we have the medical, we have the vital interest. But notice also item H, you can also share medical data without the consent of the patient for the purposes of diagnosis. Again, here, this is giving some power back to the clinicians. It's saying that sometimes it is important to share data in order to get a diagnosis, and so long as you can justify that you are doing this in the patient's best interest, you are actually allowed to do it without consent. One of the things I want to draw your attention to is that the consent in Article 9 is an explicit consent, whereas the consent that is for non-medical information, non-medical data, doesn't actually have to be explicit. So the definition of consent is given here. It is something which is freely given, specific, informed, and unambiguous. And this is very important within the context of what we're doing in the ERNs. When we are relying on consent, and that will be 99% of the time, because there will be rare cases like the sort of pediatric case I just described, we will be relying on consent. And then it's really important that that consent is informed and unambiguous. And this is really what the form is there to do, is to give the opportunity to give information, to explain to the patient what the ERN is, and to allow them to consent to it in a way that is specific and unambiguous. Now, the Commission didn't require there to be what's legally known as a cooling off period. But I know that for some hospitals, in order to really respect the concept of informed and unambiguous, what they like to do is to give the consent form to the patient, ask them to go away and think about it, maybe talk to their physician or to a nurse counsellor or whoever it is, and then come back with the informed consent. So it's not a question of giving the patient the form there and then in a consultation saying, please sign this. And the reason for that is, as we all know, it's very difficult for a patient to process information in a stressful setting. It's difficult for anybody, not just a patient. There is a so-called white coat syndrome as well, which is that if the doctor asks a patient to do something, they are likely to say yes. And so many hospitals do have this notion of the cooling off period. And that might be something very important to raise with those hospitals who say they don't like the informed consent form and they don't like this process, to say to them, well, you know, give a cooling off period, give patients a day, 2 days a week, whatever it is you want to do, to look at it, to consider it, and then to come back and give their consent. The patient's rights go beyond consent. They include, as I've already said, to be informed. It also, of course, includes the right to withhold consent. And again, this has been an issue that has been a sticking point for many countries, and it's something that we debated a long time when we were developing this form. In some countries, they don't like the consent form because they say it is too difficult for the patient to withhold their consent, or they actually don't have a capacity for a patient to withhold consent for a certain treatment, so they don't like the notion of it. And again, I think this is something that it's a matter of education, providing the right information to both the clinicians and to the patients, and to adapting to what national law is, but not of, to use an English expression, throwing the baby out with the bathwater and saying, okay, in that case we won't use the ERNs at all. Quick thing to point out, if data collection and use is based on consent, the right to data portability arises, and this could be a difficult sticking point for ERNs. Data portability means that the patient will have the right to ask for a copy of any data that you put into the system or that came out of it. Now, you've already shown that the outcome report isn't made available to the patient. Legally, the patient would actually be entitled to see all those transcripts and all the other issues. But there is a but in this. The data in those transcripts is also the private data of the clinicians involved. And so you now have two sets of privacy interests that need to be balanced. So there is an element that you could argue that the clinicians' names would have to be blocked out, but just the information that was shared would have to be shared. Again, that depends country by country, and to some extent doctor by doctor, whether they want to have their names blocked out or not. The hospital, within the CPMS system, the hospital where the patient is normally treated and that is uploading the data is the data controller. The CPM system and the commission together are also joint data controllers and data processors because they are providing the system on which the data sits. But the responsibility for the quality of the data that is put into the system, so that's the bit that I said at the beginning about making sure that it's adequate and up to date and so forth, sits with the hospital where the patient is normally resident and where the data is uploaded. The liability and responsibility for the data in transit, so that is while a consultation is going on, sits jointly with the providers of the platform and the European Commission. Once the session is closed, as you demonstrated, the data is again the responsibility of the hospital in question. So I think it was Paula who asked the question. We can come back to that again if you want to in the questions, but that's basically how the liability and the responsibility shifts. In terms of liability for the actual care provided, we have to remember this is actually a virtual consultation. The patient isn't there. It's a discussion between a group of clinicians. The care is provided by the clinician who sees the patient face to face. So the liability for the care remains with that treating hospital. Whether it is with an individual physician or whether with the hospital as a legal entity depends on how liability is set up in that country. But the system itself carries no liability for the outcome for the patient. The system itself carries liability only for the protection of the data while it is in transit. So I think it's fair to say that about 75% of the liability, both for the quality of the data that's uploaded, how the data is treated when the session is closed, and how the patient is cared for, rests with the treating physician. There is a little bit of liability that sits with the system itself, and that's a joint liability of the organization providing the platform and the European Commission. So last point here on GDPR and national law. The things that we need to be aware of, one interesting one is the age of consent. The GDPR says age of consent for sharing data can be anything between the age of 13 and 18, and it depends on the country what the responsibility is in your particular country. In Belgium, where I'm sitting at the moment, they've actually gone for 13 for the lowest possible age. In other countries, they've taken it up to 18. Many countries I know will be 16, and then you have awkward countries like the UK, which won't, or rather England, because it's English law, that don't set an age at all, but use what's known as the Gillick principle of responsibility. That is the patient mentally able to understand what they're consenting to? So they don't give you a convenient number, but it's based on the general principles of consent in medical law, in English law, which is the patient able to give consent, intellectually able to give consent? There are a couple of other slides now which are a checklist of what to do in data protection. I'm not going to go through those because I want to leave time for questions, but I think you will get these slides afterwards. So just to look at the form, the biggest challenge of writing this form, and I sometimes joke that we had a contract for 14 months and we managed to produce 2 sides, which is probably the biggest euro per word ratio the Commission has ever paid for anything. But actually, our brief was to get it onto 2 sides, and was really hard. I know we weren't successful in doing that with every language, but we were in most languages. So the front of the form explains what ERNs are, because that's the part of giving the adequate information, and you might want to supplement that with information about the ERN, the particular ERN that you're referring a patient into, or anything particular about your hospital. Then there's a section on explaining which data will be collected and why, because again, that's required by law. You have to tell people what you're collecting, why you're collecting it, what you're going to do with it, and who's going to have access to it. And the important thing here is that we talk about both the care and the research element. And again, you might want to supplement this with more information, but this does comply with what the GDPR says. And I should actually point out to you that this form has been accredited by the European Data Protection Supervisor and has actually been highlighted as a case of best practice. Then there is a bit explaining to patients what their rights are. And the really important thing here is that the patient must be given to understand that if they choose not to share their data, the hospitals will still do the best they possibly can for them. This was a big sticking point for the Netherlands, for example, who were very worried that that patients might feel they had to give their consent because otherwise they wouldn't get reasonable care. So you really need to explain to a patient, we may be able to give you better care if we can go to the ERN board, but if you choose for us not to do that, we will still do the best we possibly can. It's always a difficult balance. It's like when you ask a patient to consent to a particular test, and you can have to explain to them, if we did the test, we might know something that allows us to treat you better. And if the patient says no, you have to say, okay, we'll do the best we can without that information. It's the same sort of scenario. You then collect some information about the patient. This part of the form may vary country by country. Some countries will want to collect something like a national health number or a national ID number, or they might use a hospital number. And it's very important here, there is also a possibility to note somebody who is consenting on behalf of a patient. Pediatric case, obviously, but also a case of incapacity where you have another adult consenting on behalf of the patient. You then have to identify who the treating physician will be, who is responsible for this information. And this is because the law requires that a data subject always knows who is responsible and ultimately who they can complain to. And then you have the 3 famous boxes, and we very intentionally did this, so we have 3 sets of consent so we could get it all onto one page. The first one is, I consent to de-identified information being shared for my care, yes or no. And the de-identified bit is, as was shown at the beginning, the fact that we give a nickname. However, it is most definitely not anonymous data, because the amount of medical information you've got in there, and particularly in a rare disease, it would be very easy to identify the patient. So it's de-identified but not anonymous, yes or no. Then you have, I consent to my de-identified data being used in a registry, yes or no. And the reason that we did this separately is because we didn't want people to lose out on care because they didn't want their information to go on a registry. On the other hand, there might be somebody who says, look, I just don't want this care, but you can use my data in a registry. And then the third one is a consent to be contacted about further research. We wanted to make this consent for research, but the Commission and the member states couldn't agree on this. The Commission actually wanted us to go for consent for research, but because research is under Article 89, and there's a member state right to have national variation on that, we decided at this stage it was a right to consent to be contacted, which means that what you've done is you're allowed to keep the data on file, and you're allowed then to go back to a patient and ask them for their consent. I'm going to leave it here so that I've got time to answer your questions.
Okay, if we don't have any questions, because I only see the one on liability here, I have one. So going back to the registry, yes or no, that my question is, because once it gets into the registry, the data is anonymized?
No. Well, I say no. Usually it is classified still as de-identified or pseudonymized data. It depends how you keep your registry. It depends how aggregated your registry is and how large the registry is. In rare diseases, it is relatively unlikely that a registry would be able to meet the rules for anonymization. Because if you say you have an ultra-rare disease in Luxembourg, you're going to be one of 2, 3, 4 people. And that means that you're very identifiable just by your symptoms.
Okay, but then if I say yes to to having the data into the registry, then who can use that data?
This is where
For what? Who and for what?
Okay, this is where Article 89 of the law comes into play. The registry, it comes under the rules of public health of Article 89. The reason the registry exists is for improving the health of a population, whether it's a disease population or a country population, or for the improvement of the healthcare system. So it comes under the rubric of a national law around public health. And that means that your national law has to have said that the registry that you have in place complies with the national rules on registries. And this is one of the cases where you have an overlap between the GDPR and national rules. The GDPR says if you're going to put stuff in a registry, anonymize it if possible. If not possible, pseudonymize it. It doesn't say you have to have consent, because remember, this is public health, so you could be doing it without consent. In the ERN scenario, we went for consent because of the nature of the conditions and because we're talking about people who are easily identifiable by their conditions.
Okay.
But strictly speaking, it wouldn't have been necessary.
Okay. Okay, super. Thanks for that. Yeah, of course. Hold on a minute. There you have a question from Michelle. Go ahead.
Yes, it was just a quick comment, really. Not all European reference networks were successful in accessing the EU funding to set up a registry. So only 5 ERNs have funding to set up registries. And I do know that it's possible to, again, use CPMS to set up a registry, but that hasn't been allowed yet because more funding would need to be identified by the European Commission to extend to the ERNs that haven't got registries. It's just that small point.
Thank you.
I have a question, Alison. Okay, so Russell has a question here. We have a single consent form, but you already highlighted the issue of family privacy when dealing with family history. How can we reconcile this seemingly impossible issue?
You actually go back to basic medical ethics. You have obtained the patient's consent for using their data for their care within the ERN. The fact that you are going to bring in family history data, you're now in a different area of law. You're out of GDPR law and you're into national medical practice, medical ethics law, which means that it is your responsibility to make sure that the family data you have in there is necessary in order to treat the patient, that it is as de-identified as it can be, and that it is stored within that record in such a way that it doesn't go to other clinicians unnecessarily. So you might, for example, have within the patient's record a section which is the ERN data, which is particularly wide, and it might be the data that is normally available only to the clinical specialist, not available, for example, to the general practitioner. And you would just use the normal rules that you would have in your own country about good medical practice, about how you handle that data. It shouldn't be seen as an insurmountable balance, because you always, in healthcare, you always have recourse back to the basic principles of medical ethics, which is that it is your duty as a clinician to do your best for the patient.
When you talk about the laws of the country, though, are you talking about the referring HCP country? Because obviously this is now going to cross borders.
Yes, but as far as I understand it, the data crosses the borders momentarily. That is, during the case discussion, it is available on the system, and it is accessible, and it is discussed. When the case is closed, the report reverts back to the referring hospital.
I thought all of the CPMS data was held in Germany.
The transaction data, yes, but not the clinical data. As far as I've been told by the Commission. The Commission doesn't hold, the CPMS itself doesn't store the medical records in perpetuity. It stores them for the purposes of the intervention, and then it reverts back to the referring hospital. What the system stores is the transaction data, so that you know who logged on when and who intervened. I may be wrong. I'm basing this on what the plans were. If something has changed, then I don't know that.
But on the consent form, it did set something about something about the years that they would keep the data or something. I think it's there. Hold on.
The years that you keep the data is actually something that.
My understanding was that the CPMS system was going to remain a repository of information that could ultimately be expanded into a registry.
In which case, then it is on the basis of the law in which the CPMS is legally based. And I think you're right. I think something has changed since I last looked at this. So the organization that runs it is legally established in Ireland. The servers are in Germany, and the liability is shared jointly with the European Commission because it's a co-controller. So that's where the liability sits for the data that is stored.
And I think Germany was chosen for the simple reason that it tends to have the most restrictive data protection laws.
Absolutely.
That's why they actually chose to host it there.
Yes, I mean it's kind of become a bit of a joke in the industry, in the data protection industry, that if you can get it through in Germany, you can get it through anywhere, and that's why many American companies, for example, that choose voluntarily to follow GDPR, hold their servers in Germany, so that they have kind of got the belt and braces approach of Germany.
The problem is, however, that Germany is a federal country, and so actually it's illegal, I think, to transfer data between different regions of Germany. And certainly the German clinicians within our ERN are always the ones that are most nervous about sharing data.
Well, this is a comment often made. There is a federal data protection law, and there are Bundesländer data protection laws, but federal law, the GDPR exists at federal level, and then there may be some regional variation. But this thing about we're not allowed to share data across Bundes borders is supposed to have been addressed.
But Petra, so we don't know for sure if the data, I mean, if the Commission is holding or Open Up is holding any data. That's not. I wouldn't think that they're storing any data.
Well, the Commission made a big point of not storing, not having control over any medical data. And the reason being is that in order to be a data controller with the right to control medical data, you have to have clinicians within the team.
Yeah.
And the Commission doesn't have that, or at least no practicing clinicians. So that's why I'm a little bit hesitant about this, because the argument that was made to me by the Commission is that they are controllers only for the transactional data and for the security of the system itself.
That sounds reasonable. That sounds, yeah. I think they have, someone has raised his or her hand, but I can't. Lenya, can you help me out there? Has anybody? I see Elena has a question. I see your question here, Elena, but I think someone else is.
There's Alison, no?
Alison? Okay. So Alison, let me see if I can unmute her.
I can't see any more questions.
Alison, there you are. Allow and mute. So Alison, you can talk now, I think.
Hello, can you hear me okay?
Yes.
Yes.
So just coming back to the point on about the funding of registries and just moving on from that. So for our particular ERM, which is Epicare, we weren't successful with receiving funding for one of those 5 registries, but we are going ahead with creating our own registry on REDCap regardless. So we're trying to do it free of charge. But one of the things, and I'm working as an EPAG rep with that working group to try and help get that set up. One of the things that I've said to the group in terms of the consent form from a patient and patient family perspective is I suggested whether patients at their next appointment could, if they wanted to, that as EPAGs we could raise awareness to our patients and patient families through our patient support groups that these registries are in existence, and if you want to be placed on these registries, that you could complete a consent form and take it along to your next clinical appointment and ask, if you want to consent, ask to be included on the database. Because one of the things that I'd got from the clinicians was that they were looking at retrieving most of the patients from existing registries on specific aspects of disease or other research, historic research that had undergone in the past. And I was saying that's kind of the low-hanging fruit, and that it's not including a number of the ultra-rare disease patients within the cohort that are the ones that you really need to find the epidemiology on and those sorts of things. Just wondered what the group felt about that as an approach for other ERMs and EPAGs.
I mean, a quick comment from me is the consent form that we have at the moment is a bit heavy duty for that because it's got the 3 elements of consent in it. There may be a case to be made to the Commission to having a standalone consent form for registries. That I think legally there's no reason why that consent form shouldn't be administered, if you like, by an EPAG. What you would have to be very careful about, though, is that the data protection officer or supervisor of the hospital, which is then going to take the data and submit it to a registry, that they're happy with that form and that it meets all their requirements. And that also means that if you're going to talk about providing data to through several different hospitals, there might have to be some kind of a national approval of it.
Okay, so Council, I am able. People are leaving already because it's we're already 10 minutes late. It was a super interesting webinar. Thanks for that. We have just the last question I'm going to take is the one from Elena. Very quickly, Elena was asking something about registries. So, the registries and research are going to be ERN specific, or are they going to be exchangeable through ERNs? Can you add specific specialists from other ERNs, right? Well, maybe, do you want to answer that one?
Because you said before in the flow, you can ask specialists from other ERNs
Yes.
for their care.
Yes.
But for registries and research, are they going to be ERN specific or through the ERNs?
As far as
So who's gonna
they're
have
through the ERNs,
access?
not. I think that's going to come back to national research legislation, and that's going to be almost certainly a case of anybody who can justify to the registry that they should have an access to it, that they would be entitled to do so. And I think, as was said earlier on, that's quite a rigorous procedure to demonstrate that you have the professional credentials that mean that you're allowed access. And it will, in most countries, it almost certainly means you have to have a specific and ethically approved research project that you need access for.
Yeah, but yeah, so it won't be different from other registries in the end.
Okay.
Have to say they'll have to decide what is the law that applies, actually. Okay, but that's a longer
Thank you.
matter. We need to have a webinar on registries. No worries, we will organize one. So thank you, Michelle. Thank you, Nashida, and thank you, Petra, for being there and for accepting to participate today. Thank you, Lenya, for joining and helping me out with the questions. We have recorded this, so we will share it with the rest of the EPAGs. If you have other questions, send them to me and I will forward them to the speakers and they may address it. So thank you, everyone, and have a nice evening, you all. Bye-bye.
Thank you. Bye-bye.
Bye.
Oh.
Yay.